There is a sound that you never forget in pediatric nursing, the cry of a child in pain. It's raw, it's desperate, and it stays with you long after you've left the room. We give the medications, we follow the protocols, but sometimes, even after we've done everything we can from a medical standpoint, that pain and the fear that comes with it is still there. Because for children, pain isn't just about an injury or a procedure, it's about being in an unfamiliar place. It's about not understanding what's happening. It's about losing a sense of control. And those emotional layers can make physical pain even harder to manage. My Capstone project was built around a simple but powerful question. What if we could help children manage both the physical and emotional effects of pain without adding more medications or more side effects? The answer I found was in music therapy. Structured, individualized, evidence-based, and designed specifically for pediatric patients. Today, I'm going to share the research that supports it, the design of the program, and the impact it could have on how we manage pediatric pain. This capstone has a clear, measurable goal: to implement structured, individualized music therapy sessions for hospitalized children aged 5 to 12, aiming for at least a 30% reduction in self-reported pain scores within the first 24 hours. We know from Johnson et al. That pediatric pain is rarely just physical. Communication challenges, developmental differences, and emotional distress complicate assessment and management. And that's why we'll be utilizing the Wong-Baker Faces Pain Rating Scale to measure pain in a way that children can easily understand. But this project is more than just numbers. It's also about engagement. We'll use observational checklists like those from Redding et al. To track eye contact, facial expression, body movement, and verbal participation, along with caregiver and nurse satisfaction surveys to capture the broader impact. By gathering both quantitative and qualitative data, as well as multi-perspective feedback, we'll see not only if music therapy works, but how and for whom. The 30% benchmark is based on research by Adeboye et al. And Lowy, showing that meaningful reductions are achievable when music therapy is well integrated. And because it can be delivered by trained nurses or child life specialists, it's low cost, adaptable, and sustainable for mid-sized hospitals just like Eastern Idaho Regional Medical Center. By the end, we anticipate not just lower pain scores, but higher engagement, better satisfaction, and reduced reliance on PRN medications, creating a measurable improvement without adding costs or risk. Pain management in children isn't just a clinical responsibility, it's a moral one. And yet, despite our best pharmacologic tools, there's still a significant gap between what we can measure in a chart and what a child actually experiences during hospitalization. The reality is this: pharmacologic interventions alone are not enough. Medications like acetaminophen, NSAIDs, and even opioids can reduce pain intensity, but they rarely address the fear, anxiety, and emotional distress that come along with being hospitalized. And we know from literature that these emotional factors directly affect pain perception. Harvard Health explains that anxiety and stress amplify pain by triggering the release of cortisol and other stress hormones, which then increase the brain's sensitivity to pain signals. This means that two children with the same injury can report very different pain levels depending on their emotional state. So if we're only treating pain as a physical symptom, we're only solving half of the problem. That's where non-pharmacological interventions come in, approaches that target both the mind and the body. The Keck School of Medicine highlights how these interventions can reduce the need for sedatives and opioids in pediatric patients, helping to avoid side effects like sedation, constipation, and respiratory depression. For a child, avoiding those side effects can mean being able to sit up, interact, and even play during recovery instead of being drowsy, withdrawn, or uncomfortable in new ways. One of the most promising of these interventions is music therapy. But I'm not talking about just playing music in the background of a hospital room. I'm talking about structured, individualized sessions designed to match each child's developmental stage, preferences, and current emotional state. The neuroscience behind this is powerful. Music doesn't just engage one part of the brain, it activates multiple networks simultaneously, including the limbic system, which is involved in emotional regulation and the brain's pain modulation pathways. Listening to or engaging with music can release dopamine, a neurotransmitter associated with pleasure and reward, while lowering cortisol levels. The result? A measurable shift in both mood and pain perception. Lowy describes how music therapy can create a state of relaxation that directly impacts the autonomic nervous system, slowing the heart rate, lowering blood pressure, and promoting a sense of safety. And in pediatric care, creating a sense of safety is often half the battle. This is especially important because hospitalized children face unique barriers to expressing pain. Some lack the vocabulary, others may underreport their pain to avoid procedures or overreport it because they're anxious. The Wong-Baker Faces Pain Rating Scale, which is central to this project, helps bridge that gap by providing a visual way for children as young as 5 years old to express how they feel. But even with good assessment tools, if we're not actively reducing the emotional weight of pain, we're leaving children to cope alone with stressors that could be alleviated. And as Noble points out, music can be a powerful ally here, calming the nervous system, improving emotional regulation, and encouraging cooperation during medical care. The approach that I'm proposing isn't meant to replace medications, it's meant to work alongside them, to enhance their effectiveness, and to reduce the need for higher doses. It's about creating a more holistic model of pediatric care where we treat the child, not just the symptom. And the best part, this isn't an expensive or resource-heavy intervention. The structure I've designed allows for trained pediatric nurses or child life specialists to implement music therapy sessions with minimal disruption to workflow. Although my Capstone project is currently hypothetical, it's intentionally designed to mirror real-world hospital workflows so that implementation could happen without starting from scratch. The goal here was to make sure that the process is practical, realistic, and sustainable. The setting for this project is a pediatric intensive care unit at Eastern Idaho Regional Medical Center, a mid-sized hospital located in Idaho Falls, Idaho. I chose this setting for several reasons. It provides care for a steady flow of pediatric patients, making it possible to implement and observe the intervention with a sufficient sample size. The staff already include pediatric trained nurses and child life specialists, which means that the infrastructure for delivering non-pharmacological interventions already exists. The size of the hospital makes it a realistic model for other mid-sized facilities that might want to participate in this program. The participant group would include approximately 20 to 30 pediatric patients aged 5 through 12 years old over an 8-week implementation period. These would be children experiencing acute or procedural pain. For example, post-surgical recovery, fracture care, or invasive diagnostics are all possible things that our children might be dealing with. Here's where the project really comes to life. This intervention consists of structured, individualized music therapy sessions delivered by trained pediatric nurses or child life specialists. Music selection. The music will be tailored to the child's age, preferences, and cultural background. Research from the Pediatric Therapy Directory and Noble suggests that patient-preferred music enhances engagement and therapeutic effectiveness. This might mean upbeat, familiar songs for some children, or slower, calming pieces for others. Format. The sessions could be live, but we're planning on pre-recorded structured delivery that is intentional. Even if using recorded music, facilitators would still engage with the child before, during, and after to maximize therapeutic benefit. Session timing. Sessions can be scheduled at regular intervals like twice daily, timed before anticipated pain triggers such as dressing changes, IV starts, or physical therapy, and used as a response to real-time reports of pain and anxiety. One of the strengths of this project is the triangulated evaluation approach, gathering data from multiple perspectives and formats. The Wong-Baker Faces Pain Rating Scale is a validated, widely used tool for children aged 5 and up and has been used by Johnson et al. The child is shown 6 faces, ranging from a happy face at 0 to a crying face at 10, and asked to select the face that best matches how they feel. This method bypasses language barriers and literacy issues, making it accessible to most children within the target age range. We would record pain scores immediately before and after each music therapy session. Our observational engagement checklist, which I've adapted from Redding et al., is a tool that captures indicators such as eye contact, facial expressions, rhythmic movement or swaying, verbal participation like singing, talking about the music, etc., and relaxation cues like unclenching your fists or slowed breathing. Observations are scored to give a quantitative measurement of engagement, but notes can also capture qualitative context. For example, a child who starts tapping her foot after initially lying stiffly in bed. Caregivers and nurse satisfaction surveys. These surveys would include both Likert scale ratings for quantifiable feedback and open-ended questions to gather richer insights. Questions for caregivers might include, did you notice a change in your child's mood or comfort after music therapy? And how helpful did you feel this intervention was in easing your child's distress? Questions for nurses might focus on, did music therapy make the patient more cooperative with care? Or did it affect your ability to deliver necessary interventions? To ensure consistency and fidelity of the intervention, all staff delivering music therapy sessions would receive a brief targeted training before the project begins. This training would cover basics of music therapy principles and benefits, how to tailor music choices appropriately, how to administer and score the Wong-Baker scale and engagement checklist, how to collect feedback from caregivers and colleagues. Sessions would be documented in the patient's chart to track timing, content, and observed effects, integrating seamlessly into existing documentation workflows. The structure of this intervention is deliberate. Personalized music maximizes the likelihood of positive engagement, says Noble. Scheduled or pre-procedural timing allows us to be proactive, not just reactive. Multimodal data assessment and collection ensures that we're not just relying on a single outcome of measure. By the end of the 8 weeks, we'd have a rich data set, pain scores, engagement metrics, caregiver and nurse feedback that will allow for both statistical analysis and thematic evaluation. This combination is key to making a strong case for future, larger scale adoption. Now that we've talked about how this project would be implemented, let's focus on the outcomes we expect to see and why these outcomes matter in pediatric care settings. These aren't guesses, they're grounded in findings from high-quality research and consistent themes in the literature on pediatric pain management and music therapy. Number 1, significant reduction in pain scores. Our primary measurable outcome is pain reduction. Using the Wong-Baker Faces pain rating scale, we expect to see at least a 30% reduction in self-reported pain scores within 24 hours of starting music therapy. But why 30%? Because in pain management research, there's a threshold considered clinically meaningful, not just statistically significant, but significant enough for the patient to feel a real difference in their comfort level. This projection is supported by multiple studies. Lowy demonstrated that music therapy, when tailored to patient preferences, can lead to immediate decreases in pain perception in hospitalized children. Adeboye et al. Found that pediatric patients receiving musical interventions alongside standard pharmacological care reported substantial drops in pain scores compared to those receiving medication alone. In practice, this could mean reducing an average score from 6.5 to 4 on a 0 to 10 scale. That's the difference between a child describing their pain as hurts even more to hurts a little. And in their hospital experience, that matters. Number 2, increased patient engagement. We also anticipate a measurable increase in engagement during and after music therapy sessions. This will be tracked using our observational engagement checklist. The literature consistently supports this expectation. Noble found that children involved in music therapy demonstrated better emotional regulation, more willingness to cooperate during procedures, and improved overall mood. Redding et al. Showed that behavioral cues like rhythmic movements, smiling, or making eye contact increased significantly during structured music interventions. In our project, a child who might initially avoid eye contact or lie tensely in a bed could, after music therapy, start tapping their fingers, swaying slightly, or even engaging in conversation with staff. We expect engagement scores to more than double, moving from an average of 2.1 out of 5 to 4.3 out of 5. This isn't just nice to see. Engaged children are more receptive to care, more cooperative during procedures, and often experience less distress overall. Number 3, higher caregiver and nurse satisfaction. Pain management in pediatrics isn't just about the patient, it's also about the people caring for them. The Pediatric Therapy Directory reports that caregivers feel more reassured when they see tangible, non-invasive comfort measures being used. They feel their child's emotional needs are being acknowledged, not just their medical ones. Nurses also benefit. In studies by Timmerman et al., staff report that music therapy sessions created a calmer environment and reduced patient resistance to necessary interventions like medication administration or wound care. In our project, we expect caregiver satisfaction scores to increase from around 3.2 to 4.6 on a 5-point scale. For nurses, we anticipate reports of smoother workflows and less time spent managing patient anxiety before procedures. Number 4, reduction in PRN pain medication use. One of the secondary but highly valuable outcomes we anticipate is a modest reduction in the use of PRN pain medications. The rationale here is straightforward. If music therapy helps children feel more comfortable and less anxious, they may require fewer doses of as-needed analgesics. Research supports this. Hedayati et al. Documented a decrease in PRN analgesics use when non-pharmacological interventions were incorporated into care plans. This is a clinically significant finding because not only does it reduce the potential for side effects like sedation, constipation, or respiratory depression, but it also lowers the risk of medication errors, which is particularly important in a pediatric dosing. In our projections, PRN usage could drop from 72% of patients to about 50%. That's not an elimination of medications, and it shouldn't be, but it is a meaningful reduction that has ripple effects for safety, cost, and recovery quality. When we look at these numbers, it's tempting to see them just as data points, but each percentage represents something very real. A child who can rest more comfortably after surgery, a nurse who can perform care without struggling to calm an anxious patient, a parent who can exhale because their child is smiling again, even if just for a moment. If these projected results hold true in actual implementation, the implications are significant. Hospitals could integrate music therapy into routine pediatric care without major financial investment. Reduced PRN medication usage could lower costs and improve safety. Enhanced engagement and satisfaction could contribute to better overall recovery experiences and even potentially shorter hospital stays. And perhaps most importantly, we would have an evidence-based, low-risk, and child-centered intervention that addresses both sides of the equation, the physical and the emotional. In short, these results could serve as a blueprint for scaling music therapy across multiple units and facilities, moving it from an extra to an expected part of comprehensive pediatric care. This project also aligns with larger movements in healthcare, the shift towards holistic, patient-centered care. The Institute for Healthcare Improvement's AAA framework emphasizes improving patient experience, improving population health, and reducing costs. This intervention has the potential to contribute to all three. Better patient experience through improved comfort and emotional support. Better health outcomes through reduced stress, improved cooperation, and possible faster recovery. Lower costs through reduced medication usage and fewer complications related to unmanaged pain or anxiety. For me, this isn't just an academic exercise. I've seen firsthand how difficult it is for children to cope with pain in the hospital and how that distress affects their families and the staff caring for them. I've also seen how something as simple as a familiar song, a rhythmic beat, or a soothing melody can change a child's demeanor in a matter of moments. When I look at the evidence and I think about the real children behind those numbers, I can't help but believe that this is a path worth pursuing. Because at the end of the day, our job as nurses isn't just to treat conditions, it's to care for human beings in all of their complexity, especially the smallest and the most vulnerable among us. Music therapy aligns perfectly with that mission. It's a reminder that healthcare isn't just about curing, it's about caring. If one song can reduce fear and pain for one child, imagine what it could do for hundreds or for thousands of pediatric patients. That's the vision I'm leaving with you today. Thank you so much.